ما رو پخش کنید و همه تو ست میدم. یوتیوب نذارید ها. من شوخی ندارم. یک تو گروه خودتون میذارید. نه یوتیوب نمیدونم حواستون باشه. ندیم سر از یوتیوب و اینا ماست کردیم.
الان این خوبه دکتر. خوبه برای
یوتیوب نه چیز. مشهور نه نمیخوام مشهور.
چرا؟ اگر مشهور شما؟
نه من چون دیشب نخوریده بذارم حالم بده با سختی دارم درس میدم. Today we speak about amoeba that they have pseudopodia. After that we speak about apicomplexa that they have apicod, they penetrate, they have sexual, asexual cycle. And now we are going to speak about flagellates. Okay. So please don't confuse toxoplasma with other, okay? بقیه رفت ناپدید شدن؟ خب چون این چایاتون زودتر نخوردیم؟ کجا بودن این چایایی که الان باز دست نمیتونیم؟ نکن خورد بخور بخور هر کاری میخوایم بکنیم سر کلاس فقط این بقیه هم صدا کنه این داره همه ضبط بکنه خیلی ممنون حداقل کلاس شروع شد چیکار کنه میاد نمیاد
Isso é uma coisa que eu respondo da cola.
So in the first session we speak about amoeba that they have pseudopodia, they have mitosis, they have asexual cycle, after the most important one is entamoeba histolytica in large intestine. I told you they produce lesion, dysentery. After that we speak about coccidia. The most important one is toxoplasma gondii that have extraintestinal cycle in human, and we speak about congenital, acute toxoplasmosis, and after that we speak about coccidia. I want you memorize that coccidia, that's important in intestinal. We speak about cryptosporidium, isospora, cyclospora, that's colonized in a small intestine and produce infection, and they have sexual and asexual cycle. Now we are speaking about flagellates. Flagellates, some of them are in intestinal tract, one of them is in genital tract or genital tract, and some of them are in tissue. In the next session, the next week, Dr. Mohebali will teach you tissue flagellate. Today I speak about genital intestinal flagellate. Okay? The practical class of the intestinal flagellate is for next week. Okay? So for tomorrow, just see amoeba and coccidia. Next week, you see all the flagellate, intestinal and tissue. That's Dr. Mohebali will teach you. Okay, about the flagellate, intestinal flagellate, Giardia lamblia or Giardia lamblia, Diantoma fragilis, Kilobastis vescini, Trichomonas hominis, and in orogenital tract, just we have one protozoa, that is Trichomonas vaginalis. Here, in intestinal tract, we have Giardia and Diantoma fragilis. These are important and pathogen. These are non-pathogen. Trichomonas vaginalis also is pathogen. I don't ask question about taxonomy, but this is the taxonomy of flagellates. That's in the subphylum Masticophora. In the class of Zoomasticophora, we have different family, we have different Giardia, but the most important is Giardia, Lamblia or Giardia, the Duodenalis, Intestinalis, all of them are the same. If you Google it and see other name, all of them are the same. First, let's speak about Giardia lamblia, also known as Giardia duodenalis, intestinalis, because what? Because it is colonized in a small intestinal tract. The most common protozoa in intestinal tract in the upper small bowel that can induce diarrhea is Giardia. It can infect all the human, but it is mostly prevalent in children. In children, in normal people, it can induce symptoms, and we should treat that. But in children, the symptoms is more severe. So in normal people also we have symptoms, but it can limit it. We can, with the drug, it can limit. But in children, the symptom is much more severe. In HIV or immunodeficiency also, the symptoms is intensified. It is worldwide distributed, but in low sanitation because it is oral fecal or oral anal. So in low hygiene or sanitation, or poor water quality, unhygienic environments, it can be spread, and also in overcrowded places or country is much more distributed. Giardia is the prevalence is more than histological because with Giardia has animal reservoir. Histologica is specific for human, but Giardia, besides human, we have animal reservoir, so it helps to have a cycle and more distributed. About the morphology, we have the trophozoites and the cyspore. The trophozoite is very strange, very simple for your exam. If we said the Giardia lamblia, it's hair-shaped. Okay, at the anterior end they have two nucleus with the big karyosome, and they have 4 hair flagellates, 2 of them from anterior, 4 of them from lateral, and 2 of them from posterior end come out from the protozoa. In the staining, maybe you can see these flagellates. Based on the whole shape of the cell, you can distinguish it very simply, rapidly. It's very simple. And if you see that, you can see the flagellate. Based on the shape of the cell, you can see. It's like an eye and nose. Also, in the middle of the cell, they have C-shaped body, that we said median body, 2 median body, that's C-shaped, and they can attach and very colorful. These are some sort of cytoskeleton that help for maintenance of the whole shape of the cell. In microscope, electron microscope, if you see, this is the light microscope, this is electronic microscope. They have a posterior end and they have a sucker plate. They have a sucker plate here. This sucker plate helps them to attach to the epithelial cell of intestinal tract. So at the ventral side, Here you can see, this is the sucker plate. At the ventral side, they have a sucker plate or sucker disc, and because of that, they can attach to the epithelial cell. They produce the cyst form. The cysts first have 2 nucleus, but they multiply, and all of the details are multiplied. 4 nucleus, the flagellate, and the median body. Between the cyst wall and the protozoa, there is a gap. This is and it is oval shape. This is the cyst form of Giardia. About the cycle is very simple. This is a colonizing the small intestinal tract. We eat or drink the water or food that's contaminated with the cyst. Cysts come to the small intestinal tract. In the small intestinal tract, they rupture. 2 trophozoites come out, and they multiply. So the cycle is very simple. In coccidia, we have sexual cycle, but here we don't have any sexual cycle. They are doing mitosis, very simple, and the trophozoite and cyst can pass through the stool. In acute phase, we mostly have trophozoite, but in the chronic, we mostly have cyst form. But both of them can be seen in the stool. But as I told you in histolytica, the trophozoite isn't infective stage. It is degrade outside, or if we eat the trophozoite in the stomach because of the acidic pH, or in the mouth, they degrade. The infective stage is the cyst wall, because the cyst wall is produced from the cellulose. It is resistant to the acidic pH of the stomach. They pass through the stomach, go to the small intestine, and excitation happen. The cyst rupture and the trophozoite come out. Important things for your exam. The pathogenicity mechanism of Giardia. This is the electron microscopy. When we infected with Giardia, they multiply, the number of parasites is increasing. They cover the small intestine and attach tightly with the sucker plate to a small intestine. Epithelium. Do you pass physiology or pathology? The epithelial cell of a small intestine totally different from large intestine. We have so many villi in a small intestine because in this small intestine the duty is absorption of the nutrient. So we have so many villi. They can attach and cover this microvilli and produce a physical coverage. So they interrupted absorbance of the nutrients, and also they can decrease absorption of the vitamin, lipid, and somehow they compete with the host for absorption of the nutrient, because epithelial cell should absorb, and this cell also absorb the nutrient. So gradually the patients have deficit in absorption of the nutrient. Also, they produce or secrete some toxin, and this toxin produce the diarrhea. Okay, this toxin produce the diarrhea. One of the things that's happened here also, they can degrade the bile salt. Do you know that the bile salt and so many enzymes such as lipase, trypsin, they are very important in degradation of the fatty acid. Okay? When they degrade bile salt and these enzymes, the fatty acid, okay, the fatty acid don't degrade. So the undigested fatty is spread through the stool. So the patient had diarrhea that's full of the undigested fatty. It said steatorrhea. Okay, steatorrhea means diarrhea full of fatty. It's like reddish. The stool, sort of reddish, no, yellowish, yellow. The stool or diarrhea is sort of yellow because it's full of undigested fatty. So based on the pathogenicity mechanism, we have problem in the absorption, in the digestion of fatty acid. So memorize that for your exam, and I ask question, you should compare it with histolytica. Histolytica is in large intestine. Histolytica produce lesion. We have blood, we have RBC in the stool, we have the dysentery. But here we have the protozoa in the small intestine. So the mechanism totally different. They invade, histolytica invade, produce lesion, produce antibody. We use serology for diagnosis. But Giardia, we don't have any invasion. And the location is totally different. It is in a small intestine. But we have some factors that can intensify the symptoms. For example, apopleuria. Apopleuria, in some people, because of, for example, using, for example, aluminum Mg. You heard about that, or some genetically HCl or hydrochloride acid. You know that the gastric tract, the stomach is full of acid. Yes. In some patients, genetically or because of continuously using, for example, aluminum Mg or some drug, the HCl is reducing, or lower than normal people. These patients, these people, they are more susceptible. They are more susceptible. If they infect with Giardia, because they have lower HCl, the parasites multiply more than normal. This acidic can limit the multiplication of the parasite. When the HCl is lower, they can multiply very simply, rapidly. The more parasites, the more symptoms. So in these people, the symptoms is much more severe. Number of digested cysts, for example, the source of infection. If the number of the parasites or the cyst in the contaminated water is higher, the number of parasites. Why? Because parasites cover the epithelial cell. The more number of parasites, the more coverage, the more degradation of the bile, and the symptoms is much more higher. Immunodeficiency, I told you that all the mucosal, vagina, intestinal tract, all the mucosa we have on IgA, secretory IgA. Some people genetically don't have this IgA, or the number of or the amount of secretion of IgA is lower, or these are more susceptible. All the microbial agents rapidly can attach and penetrate. Also, in any deficiency, immunodeficiency, innate or acute like AIDS, like HIV, all of these patients are more susceptible, and the symptoms is intensified, more intense. The other things is blood group A. If you pass the immunology, all the microbial agents have antigen, and immune system we should recognize these antigen, and based on that produce antibody, and after that degrade the microbe, for example the Giardia or parasite or anything. It was demonstrated that in patients that have blood group A, the antigen of blood group A is similar to antigen of Giardia. So the immune system, because of the similar antigen of antigen A to antigen of Giardia, the immune system don't recognize antigen of Giardia because it's the same as our antigen, and because of that, because of this similarity, don't have produced antibody against that. It's like escaping from immune system. One of the mechanisms of the microbial agents that escape from the immune system is similarity of their antigen to our blood group or any antigen that's inside our body. In this situation, immune system, when they don't produce antibody, Giardia can replicate without any immune system, without any limitation, so the number of parasites is increasing and the symptoms is much more than normal people. So memorize about these two slides, okay? The clinical symptoms is diarrhea, and mostly I underline important one. Steatorrhea, sometimes they can go to gallbladder and produce cholecystitis. In some individuals, they don't have any symptoms or asymptomatic or symptomless, but sometimes they produce symptoms, and I told you in immunocompromised, the symptoms is much more higher, and I don't want you to memorize about incubation time or the time that passed. Just memorize this one, okay, and underline that. About the laboratory diagnosis, because the Giardia is in the small intestine, the parasite pass through the through the stool. So the stool exam is very convenient, very simple, and we simply can ask for a stool exam. We can do concentration direct. I don't want you to memorize that. Just know about the stool exam. But you should know that I told you that a stool exam you do 3 times. 3 times a stool exam you should do 3 times. Why? Because secretion or release or passing of the protozoa is intermittently. For example, when you in the patient in one time it is negative, 2 times negative, in the third specimen it is positive. Okay, passing of the protozoa most of the times is intermittently. So with just one specimen, we maybe miss the diagnosis. Sometimes, for example, in endoscopy, sometimes they prepare aspiration from the beginning of the small intestine from jejunal, and they transfer it to the laboratory, and we can check the parasites in the aspiration. These are the Giardia in the wet mouse, in the iodine state. But in your class, in your practical class, these are permanent staining. You can see the detail. It's very hard. And in the laboratory diagnosis, they don't stain with permanent staining like trichoro. With wet mouse, without any permanent staining, they should recognize. Because of that, the experience of the technician, the experience of the laboratory is very important in a stool exam. These are the trophozoite, these are the cysts. About the treatment, we use metronidazole. But for the children, I told you, in children also we have Giardia, we use furazolidone. We don't use metronidazole for Giardia. So in the flagellate, the most important that we should, definitely I ask you question in your quiz. Giardia, I ask question definitely, so check about the items that I told you is important. And compare the pathogenicity of Histolytica and Giardia. Don't confuse them, okay? The other important protozoa is the Entomologia fragilis. It is in colon, large intestine. It just has the trophozoite form. It has the Entomologia fragilis. It has two nucleus, and the nucleus it has fragmented chylosome. This is the nucleus, and the cytoplasmic granula. It is in the large intestine, and it can produce diarrhea. So it is in large intestine. Okay. I don't want you to memorize the cycle. Okay. میدارم خلاصه میکنم براتون. They produce mucosal diarrhea because my lesson درس من full of name, and I know that it's very hard. Laboratory diagnosis, just memorize about the stool exam, and about the treatment is metronidazole. If you listen to my voice, you can summarize all these slides in where also we have kinematics destiny. I omit it from your lesson just because in your curriculum, just you know that this is non-pathogen. If the laboratory diagnose for you, report kinematics is non-pathogen, and there is no need for treatment. It is non-pathogen. You should know that because laboratory, anything that they see, they report for you. It is up to you that treat your patient or kill him or not. And امیدی ندارم البته پیشنتتون سروایو پیدا کنه. حالا they have trophozoite and cyst, but it is non-pathogen. For laboratory diagnosis, so kilomasis, I don't want you to memorize, okay?
Okay.
This lesson is simple. about the trichomonas. Trichomonas, we have trichomonas, different variety of trichomonas, but three of them that colonize in our body is Trichomonas vaginalis, Tenax, hominis. Tenax is in oral cavity, hominis in colon. They are non-pathogen. If they report for you, there is no need for treat them. You know that metronidazole has so many side effects. Okay, and unfortunately, physician, any parasite, non-pathogen, report in the laboratory, they میبندن پیشنتشون رو به metronidazole. For example, 10 days they use metronidazole, that there is no need for treatment. So you should know that which of them is necessary for treat or not. What about the Trichomonas vaginalis? What?
I said it's pathogenic, right?
Trichomonas vaginalis is pathogenic, yes. Trichomonas vaginalis is pathogenic, and one of the important sexually transmitted disease, we have STD. If you Google it, we have STD, we have one microbial for diagnosis STD, some microbial agents, classified as sexual transmitted disease, and one of them is Trichomonas vaginalis. Totally, the most important things about that is, in men, usually it is asymptomatic without any symptom, but in women, most of the times it produces symptoms. About the morphology, it has flagellate, 4 flagellates at the anterior end. In other side, they have undulating membrane, and the one flagellate attached to these undulating membrane. So one flagellate attached to these undulating membrane, and if they are very motile, in the cell they have some cytoskeleton, such as pasta, such as oxosteel. These are helpful preserve the maintenance of the shape of the cells. They have the nucleus. When we stain it, this is undulating membrane. These oxosteel start from anterior to posterior, and this is the nucleus. They don't have any cyst form, although it is pear-shaped, but in our body, they are, and when they attach to the mucosa of the vagina or genital tract, they have some like pseudopodia, because they attach to the cell and absorb the nutrients from the cell. They don't invade like histological to the submucosa, but because of this attachment, they can absorb the nutrients from these cells, and they produce some enzyme, some toxin. We have so many glycogenic cells in the epithelial of vagina and cervix. They can feed and digest these glycogenic cells, because these epithelial cells full of the glycogenic body, and because of these glycogenic cells, they can feed on these cells, but they don't invade. This is electron microscope. In women, they produce vaginitis, but in men, I told you most of the times, we don't have any symptoms, but they can produce urethritis. Also in men, all the epididyme, prostatite, all of these can be infected with Trichomonas vaginalis, and most of the times they don't have any symptoms, but sometimes they have itching, irritation, or some discharge. They have some discharge, but in the women, most of the times they have symptoms. In women, I think when Trichomonas vaginalis attach, they multiply. Besides that, the immune system penetrates and accumulates on the area that's affected with Trichomonas, and we have some capillary, and because of the inflammation, the capillary is enlarged. So because of capillary dilation and immune system that happened here, we have some reddish spotty on the vagina. Here. These spotty, these reddish spots, these are because of the capillary dilation and immune response, and because of the erythematous cervix, we see these erythematous cervix with punctuation area of exudation. What is mean punctuate area of exudation? These punctuate area in these exudation because of the accumulation of the Trichomonas vaginalis and immune response and dilation of the vessel. This dilation of the vessel and the infiltration of the immune cell because of the attack Trichomonas vaginalis, and because of that we have some spots, reddish spots, and the appearance of cervix is red, and these are more reddish. So this is, we say estuary cervix. Okay. This is the hallmark of the Trichomonas vaginalis. Okay. Besides that, the gynecologists, when they see the cervix and these spots, they definitely can diagnose Trichomonas vaginalis. But sometimes they can prepare a specimen from these spots and transport to the laboratory for the diagnosis. Besides that, they have some discharge that's white to yellowish and sometimes trends to sometimes greenish. About the diagnosis, if the specimens, we have the specimen, we can do direct exam culture. Also in the pap smear, we also can see the Trichomonas vaginalis. We can use permanent staining for the Trichomonas vaginalis. You can see Trichomonas vaginalis in the culture and also in the discharge of the vagina. The big cell that you see, the big purple cell is epithelial cell, and all the purple, dark purple are Trichomonas vaginalis. We can use for treatment metronidazole. Please memorize that. We use metronidazole. This is also, you see, these are epithelial cells, these are Trichomonas vaginalis. You see, it's very hard for diagnosis. The last protozoa is the ciliate. The only ciliate that, so in the flagella, you should pay attention to Giardia, the entomophagy, but the entomophagy is very simple about the Giardia pathogenicity and the factors that intensify and or help to severe the symptoms you should memorize for your exam. About the ciliate, the other protozoa that can infect human is Balantidium coli. The only ciliate that can infect human is Balantidium coli. they are very big, they are in large intestine. In the second, we have trophozoite and cystoid. The trophozoite covered with cilia. They have cytosome at the anterior end. In the cell, we have macronucleus and micronucleus. Macronucleus is bean shaped, it's very large. Micronucleus very small. They produce the cystoid. The infective stage is the cystoid. About the cycle, if they are in large intestine, they multiply and they can be pathogen. They can produce ulcer or lesion in the large intestine. Sometimes the symptoms that the Balantidium coli induce is like histolytica. I told you that histolytica in large intestine can produce lesion and dysentery. And Balantidium coli also is a ciliate that can produce lesion, dysentery, and can produce sometimes symptoms, and ulceration is like histolytica. But in histolytica we have extraintestinal amoebiasis. Here we don't have extraintestinal amoebiasis. In some reports they reported it can produce extraintestinal, but it's not common. It's totally different from histolytica, but they can produce some lesion and dysentery like histolytica. And the test that we use for diagnosis is stool exam. We use tetracycline for treatment. For histolytica, the best choice is metronidazole, but here is tetracycline. Because the genus and parasite is totally different. Histolytica is amoeba, and this is ciliate. This is the cystoid, and this is trophozoite, and this is cystoid. This is permanent staining. This is wet mount.
This is the last one.
من همین الان حذف میکنم.
حذف کنید.
مشکلی نیست. برای الان
تو رو میدوستم. میدوستم بشکن.
من میکنیم.
همین الان.
فقط اون برسید پایین.
خوری رو بکنم. خب یکی دیگه هست. Belastocystis hominis is the parasite also is intestinal tract. It has different shape, but the most important one is vacuolar form. They have a central body. Around the central body, it has from 5 to 10 nucleus. They have different shape, granular, amoebic, but the most common form is vacuolar form. They are in large intestinal tract, and previously, just I want to know, that previously Belastocystis is non-pathogen, but nowadays in CDC, if the number of Belastocystis in each shunt of microscope more than 5, we should report that. And if the patient have symptoms and we report Belastocystis, the physician should treat it with metronidazole. And also suggested that it can be related to IBS or IBD. Irritation, bowel syndrome, or irritation, bowel dysfunction. It's because of the stress. So previously we don't treat this, but now if the number of Belastocystis, if the patient has symptoms and the number of Belastocystis is high, it's preferred we should treat that. and stool exam and treatment is spectrum. اوکی تمام شد.